Oh, hey, Chris.
Hey Chuck, how are you?
I am doing well. How are you tonight?
I am great. I'm great. I am staring at a piece of apple pie that I'm going to eat as soon as we're done with this.
That is incentive to get done.
It's been a staring contest. It's interesting. I am not shy when I talk in the OR about my love and appreciation for food. And she had a one of our RN first assists. His wife, or he convinced his wife to make an apple pie for me. It's
Wow.
literally the best apple pie I've ever had.
That is awesome. I am seriously jealous. I had an interesting day. I had a great day. I have intermittently been able to ride my bike to work, but I was able to do it today. It was a little chilly this morning. It was around 50, but coming home, it was 75. I came home at like 6. I left at 6 and it was 75 and sunny. My God, it was awesome.
Oh, it was a gorgeous day. I actually came home and both of my kids were in bathing suits, and I was like, "Did y'all get in the pool?" I was like, "I didn't heat it up, but it must have been so nice outside that they just could not resist."
Yeah, you and I might not have enjoyed that pool, but
Mm-mm.
kids are immune.
Yeah, I actually saw. I walked by our chairman's office today. I saw a bike in his office too. Was it yours or was it his?
We do not share an office. It's his. He has a very short commute, but he does ride often.
Very good, very good. Well, good for you. I look forward to seeing you out and about, riding across Forest Park.
Absolutely, I have the best path to work.
My son still reminds me of that one time during the I guess I can't remember what random day it was, but I actually biked him to school. Like he was on his bike, I was on my bike, and we had a good time. But it's been a while.
We had a little hiccup there, but I think we're back. All right, I think we're doing an interesting episode, one that I'm kind of looking forward to. We're going to do a little bit of a grab bag with a couple of emails and a couple of cases. Does that sound like fun?
It sounds like fun. Did you get an email from Down Under recently?
I did. I would say so. Richard Lawson is a great guy. He's a good friend, although I don't see him enough, who I first met on my Bunnell traveling fellowship when I went down to visit Michael Tonkin. And Michael kind of pawned me off on Richard, who took me to a gym to do rock climbing. And it was super fun. And I was super grateful that he was hanging out with me. And while again, we don't see each other often, he's just a really, really nice guy. So I was interacting with him about something. Um, and he kind of threw in there casually that, oh, yeah, I broke my humerus. I'm like,
Wait,
what?
wait. So is he a hand surgeon?
Yeah, he's a hand surgeon. Absolutely. In Sydney.
Got it. Got it. Okay. So he how did he break his humerus?
I'm just gonna. I asked, and he gave me support. So I'm going to just read his email. It's not that long, and I think it's actually pretty telling. So, hi Chuck, I love the podcast. Well done, Sarah. And he's speaking of Sarah Tollerton. Brought it to my attention, and it is very good. You guys have an excellent rapport. Uh, Thank you, Richard. I have to carry Chris on this podcast, but
Yeah, it's, just a workman hammering nails again. Just going at it.
All right. The story of the left arm. Unfortunately, not very glamorous. It was, but what's great for me, and part of the reason I wanted to read this is it's just hearing an Australian put things into written form. It's very different than what.
I was really hoping you were going to read this with an Australian accent. So,
No,
maybe we can do a take two on this one.
no, you can do it. The story of the left arm. Unfortunately, not very glamorous. It was blowing a gale at the rowing sheds. I've never uttered that in my
Is that
life.
what English, American English, please?
It was really windy at the pond. Probably no one should have been out. Some friends put their double in the water. The wind took the aluminum and cloth stretchers, and one sailed into the water between our nice, modern, non-slip pontoon and the neighboring not-so-good structure. I jumped onto this and down I went. Big jolt through the radial and ulnar nerves. Thought shoulder dislocation, but palpation revealed a midshaft fracture, which is
Oof.
said like such an orthopedic surgeon. I'm going to keep going. A very good trauma surgical friend of mine plated it posteriorly, and I am pleased to say it has united with no nerve problems. Lessons learned. Number one, fractures are painful. Wearing a sling from clothing is worse than a paper sling, which is worse than a cloth sling. Can't argue with that. It is interesting how we see people on the day, the next day, 2 weeks, 6 weeks, and 3 months. And at each of those time points, the patient is usually better, but the line joining those dots is not necessarily smooth. I think that is well said. Long bone fractures in adults are exhausted. After the first week, I went back to consulting and did 3 half days and just went straight back to bed after each morning. Muscles take ages to heal. I followed my surgeon's advice and avoided any rowing and weights for 3 months, then went back obviously too eagerly, training just about every day, but I thought fairly gently. It all caught up with me, and by 2 weeks, I had to stop due to arm pain, taking the rest of the season off. Life is better with exercises, and rowing has been tough not doing the thing I love for almost 5 months. And there you have it. This is sage advice, try to keep your long bones intact. As I get older, I think about that a lot.
That's amazing. And I would say, hell, try to keep all your bones intact, not just the long bones, including the bones you can swallow.
Yeah, keep them all intact. But the long bones, I must admit, I haven't had a long bone fracture, although one of our partners recently has. Let's keep them intact.
Well, so 2 things.
Nice.
The first one is that actually our partner who fractured his tibia knew he fractured his tibia as soon as he did it, based on the same instincts that your buddy had as well. It was a ski boot kind of thing. And he's like, I'm pretty sure I have a mid-shaft tibia, like when EMS was putting him in the cart. So he knew. The second thing is more serious, and I think it is super important. I think that as we try to teach ourselves and teach our trainees technique, being really good about taking care of muscle. I kind of make a joke about it, but one of the things that Dean Lorich was really big about was very elegant, sharp dissection with a knife, with a scalpel, and learning how to dissect with it. And his quote all the time was, "Don't make dog meat out of this." And that's obviously a very callous thing to say, but I've honestly found myself saying, don't make dog meat out of this when we're doing some of the dissections where you want to be very kind to the muscle and try to keep the fascial planes intact because of the kind of pain that you're describing. The more patients you see post-op, the more you hear them say, this muscle hurts or something. Some of the dissections that we do are deeper, are more prone to having that kind of pain.
Oh, I think that's well said. I think back to when I was a resident, I may have said this before, when there wasn't a paratricipital approach to the distal humerus, we went straight through the triceps.
Ooh, ouch.
Right down the middle. And it was stunning to me, and I hated it for that reason. And now I love the posterior approach to the humerus, because you just move the triceps out of the way. It's like such a no-brainer.
Well, I think that's also why, for a submuscular transposition, it's why that surgery hurts so darn much, is that just all of that muscle manipulation. I mean, that is one reason to avoid that surgery if you can. That's
the reason I do. It's why it's not my first choice. There are certainly those who argue do the last surgery first, which would be a submuscular, but I don't think it's that simple. It's not my first surgery.
Yeah, I think that if, I think I've shared this with you before, but when I was visiting Elizabeth Hoggart, she looked me in the eye and said, "Would you have that surgery?" I said, "Not unless I had to." And that was a moment for me where I reconsidered my algorithm a bit.
All right. I think you received an interesting email as well this week.
Yeah. So, thanks to those of you that send emails in. It really, it's helpful for us to know what questions you want answered, and also just to get your feedback. So Ryan Caldwell is a hand surgery fellow at Tufts. And Ryan, thank you for the email. And I'm going to go ahead and read it. He starts by saying, "Thank you for your podcast. You've created an entertaining and valuable resource for hand surgery trainees like myself, and it's been very helpful to me as I start my practice. We've enjoyed doing it, so thank you for tuning in." And he goes on to say, "I'm intrigued at the large benefit that sham surgery shows in trials, both in and out of the upper extremity, the power of suggestion, the scripted role of the patient getting better, especially if they like their doctor, The immobilization, the emotional validation of having a surgery, it all seems to add up to a very powerful therapeutic effect. There are also several pathologies that seem to be treated equally well with many different surgical techniques, sometimes based on fundamentally different theories of pathophysiology, such as various debridements of the lateral epicondyle for lateral epicondylitis, or some of the various treatments for Kienbach's disease, whether you're doing vascularized bone grafting, shortening the radius, or even a core decompression. Again, chronic SL reconstruction, like rotator cuff repair, seems to produce good clinical results despite radiographic progression or recurrence of deformity. Something seems amiss. Does surgery for epicondylitis, TFCC tears, proximal nerve compression syndromes, Kienbach's chronic SL, etc., help my patients apart from the placebo effect of surgery? How can I be sure? So, pretty straightforward, easy question, Chuck. Why don't you take this and answer it in 2 sentences?
Yeah, I'll answer. I'll take this one, Chris. It's interesting because all I really want is for the patient to be better. I'd like to do that in a non-interventional way. I'd like to do it rapidly. I'd like to do it with low cost. And I recognize that there is a placebo effect, but our goal is to just get patients better. And many of the surgeries that Ryan mentioned, I don't love. And I'll share one brief anecdote. Early in my career, I was the designee, and that's why I started to love wrist arthroscopy, because no one else really wanted to do it, and that's why I started doing it. And we debrided central tears, we debrided radial tears, and we repaired ulnar tears, even though we didn't recognize TFC-related instability, or at least I did not. And I always wondered, and Marty and I talked about whether repairing those dorsal ulnar tears did anything, because this wasn't a stability issue. It was just you were doing something, and really you were immobilizing them, and they got better. And that's an example, I think, where I was over treating. And today I might just debride that unless it was a very large tear. Again, foveal TFCC tears are a different story. They're about stability. But I think he makes a good point. I don't like lateral epicondylitis surgery. I agree that lots of different ways to approach that, but we want to get the patient better, and many, if not all, of the surgeries mentioned can help achieve that result.
How much of the improvement, and Ryan, thank you for getting us to a very philosophical level here, but in a very nicely worded email, eloquent. How many of these surgeries, or how much of the improvement after surgery do you think is from the other things that Ryan stated? And I think it's really important. Suggestion, the scripted role of the patient getting better, immobilization, emotional validation of having surgery. How much of that do you think is part of it?
All of it is part of it. And we talked about it on our last episode about ECU tendon, and maybe part of it's just immobilizing the patient for 6 weeks after surgery. It's all a part of it. One of the reasons I like fracture surgery is you fix the broken bone. It's very objective, and all this other stuff is less so.
I think that one of the reasons why fracture surgery is so gratifying is that not only can you see it, the patient can see it. Like, you can show that to them. It's very hard to show patients other things, effectively, either because they can't see it and it's based on how they feel, or because it's just really hard to explain, some of these concepts of scapholunate instability, for example, that we don't even fully understand.
Yep, totally agree. It is interesting, though. The flip side of what you just said is, if you treat a patient for a fracture and they develop a painless fibrous non-union, we might be okay with that, but sometimes patients are not.
Right, and that's where I start to lay the crate from the very beginning. No, I think they're, of the surgeries you listed at the end, each of those has value when done in the appropriate setting. Now, of course, I'm biased because we're the arbiters of what's appropriate, fair or not. But I've tried to take, I've tried very firmly to avoid the supply-induced demand. Just because I can do something doesn't mean that I should do it. But I can see very easily how, if you have a run of good experiences with some cases, you're going to push the limits on some stuff. and really feel like in your heart of hearts that you're doing something for that patient, and maybe they are going to do well because of the other reasons that you stated.
Yeah, it's a really tough concept. And I can sit here and be judgmental of people who've gotten a great result from something I don't do. And that may not be fair. And I think it is incumbent on all of us to practice appropriate medicine. And sometimes it's easier said than done if the patient's putting pressure on you about an intervention, and it just gets really tricky. But you want to sleep well at night, and that is not always a way to think about it, because if your directionality, you can deceive yourself about whatever you want to do. So it's not always about sleeping well, but that's my threshold. And I try to be scientific. I try to follow the literature, and I feel pretty comfortable that I don't overtreat people.
I try to be a good steward for testing and that kind of stuff. But sometimes, honestly, some patients just want some imaging that maybe I would not have ordered, but I actually know that just getting the fact that I'm getting something and doing something for them is therapeutic. So I am guilty of ordering some therapeutic imaging at times.
For sure. And I will add, one of the best things about being in academic medicine is you have people judging each step you take. You have residents and fellows questioning while you're doing something, and you can't kid yourself and you can't deceive yourself, and you have to be able to defend yourself, not just do it because I said to do it.
They don't question you though, right?
When people come on my rotation, now I don't know if they do or not, but when people come on rotation, that's the first rule. If we are in the OR, if we are in the clinic and something doesn't feel right, or you don't think I'm doing the right thing, I expect you to speak up. And if you don't, and something goes amiss, I will be really disappointed. People have
You never gave me that first rule. The first rule was don't sing.
The second rule was don't speak up, Dr. D.
It's on a lighter note, I remember getting sign out about your rotation. And it was so funny because like when you're an attending, people will think that you want all these things or don't want certain things. And it's just this like lore that gets passed down that, Goldfarb wants things exactly this way every time. And it's probably because like some random thing happened one time and they just like took it to heart. But yeah, it's very funny to see how you actually practice and your actual preferences versus what I was told about you.
Yeah, I'm sure that's true. I'm sure that's true. I love that conversation. There's no easy answers, as you obviously know, as we all know, but it's an interesting conversation.
Now I think Ryan deserves a mug, Chuck. Are there any mugs left?
There are a few mugs left. We should get Ryan's address. Ryan, if you're listening, send us your address and we will send you a mug.
Fantastic. And I think we also owe one of our former fellows a mug. One of the things that we said was if they published an article from their fellow research project that they would get a mug. And your mentee on this project, Dr. Jocelyn Compton, recently scored a nice JHS publication on how none of us need to fix Jersey fingers anymore. So bravo, definitely mug worthy.
Have we talked about that article? I think it's a super
We did. We talked
article.
about it. We talked about it on the Hand Society wrap up when it won the award for the best poster.
Yeah, it is a really interesting article. Read it, everyone, in Journal of Hand Surgery. It does not say don't fix FDPs, but it does question why it's a knee-jerk reaction, because complications are higher and outcomes are not clearly better for many.
No, I took that as don't fix them, or send them to the senior author of Dr. Compton's article.
Oh, please don't.
That's exactly what you want, a bunch of non-op zone ones in your.
Yes, exactly. Tell me about an interesting case you've done recently.
So you remember when we were talking about our radial tunnel technique, and you said, yeah, just go anterior. And then I joked and said, well, you don't like to release all of the radial tunnel. So recently, yeah. Recently, I saw a patient and ended up revising a radial tunnel, and it was the exact textbook kind of distal compression, and to the point where we examined her in the pre-op and put an X on where they were maximally tender, and lo and behold, that's where the residual supinator was. And the first surgery had been done through an anterior approach by an excellent surgeon. But it's just one of those things that it's really hard to see the distal end of the supinator. And I don't go dorsal very often in isolated manner, and that is a humbling approach to do when you're trying to just perfectly get the fascial planes and not make dog meat, as I mentioned earlier. And if you're even just a plane or two off, a couple of clicks off, that can change your whole approach and clearly obscure where you need to be.
I think that's well said. I like a couple of things that you said. The first is that, and I've said this over and over, I love examining and marking patients in the preoperative holding area. I mark my incisions, I mark the masses, and I mark the areas of greatest discomfort. So I love that for radial tunnel. That's a super helpful thing. And I think it can guide your approach. So love that.
I don't do the dorsal approach often in isolation. The other case I'll share with you guys later, I use the dorsal approach as an accessory, but a pure dorsal approach is challenging, and especially when you start to encounter scar. And that's when it gets real and very challenging to try to free up the PIN in an area where you've got a lot of small vessels, you're around a lot of muscle. It's not exactly the easiest surgery in a revision setting.
Yeah, I did that very similar surgery for different reason, but I took a patient to the OR who had proximal radioulnar proximal radioulnar impingement after radial head replacement and removal of the radial head implant. And so with rotation, he was impinging radius on ulna. And so the first thing I did was find the radial nerve and find it entering and exiting the supinator and kept it safe. And then I created an interposition combination of Anconeus and allograft. Super fun surgery, super trying surgery. But that approach, as you just said, with scar tissue can be tricky, but feels really good when you see the anatomy as you described.
Now, is that a dual incision approach?
I did not. I just went sort of an extended Anconeus approach, really sort of where they made the previous incision, but I just made it a little bit longer.
We should, in a future episode, spend some time talking about proximal radioulnar synostosis. That's a tough condition to treat.
Unfortunately, I have experience with both synostosis and impingement, and I really, as you know, have really started to love elbow. So yeah, I think that'd be a fun episode.
I'm glad you love elbow.
Many have said that to me.
But then, the other part that was interesting about this case is that they had come in with an ultrasound from elsewhere, and the ultrasound from elsewhere showed that the superficial radial nerve was not enlarged compared to the opposite side. But she had tunnels that would, coincided with the area where the superficial radial nerve exits from underneath the brachioradialis, and she was dysesthetic in the SRN distribution. Motor-wise, had recovered everything from her last surgery, but we went ahead and did the SRN decompression and the brachioradialis tenotomy, and the nerve just didn't look right. And it's totally like a squishy, very kind of anecdotal and soft call, but it just didn't look right. And I think you could feel and see the area where the nerve, was not normal. I can't say it was terribly enlarged, but I think maybe I'm rationalizing along maybe of what Ryan was saying in his email, but rationalizing to myself that it was the right thing to do to add that distal decompression.
I'm sure it was the right thing to do, because when you should have more freedom to do a little bit more in a revision situation. Obviously you want to get everything done right the first time when possible, but in a revision situation, you have to be willing to do more because you want to not be back a third time.
Right, exactly. And the last thing I'll add is that in preparing for the case, I cracked open the old Gelberman Blue Book from 1993, which I love that book, by the way. I mean, I'm such a nut for textbooks, as we talked about earlier. And it talks about the total off the cuff, like level 5 evidence, but it says the rate of distal compression, meaning, it's at the distal edge of the supinator being 5%. That number felt right to me. Maybe it's a little high, but does that number feel right to you?
That number feels right to me as well. Very low, but it's not zero.
Right. Now, that Graham Lister knew what he was talking about.
Yeah, just a little bit. Can I share something with you about a case?
Yeah, absolutely.
It's a case that you will never do, Dr. D, but
Oh, thank goodness.
I think the discussion around it is super
Let me guess.
interesting.
Did you make a thumb out of something?
No, but that'll be part of this child's treatment. So I want to leave out some of the demographics and the like, but I treated a patient with ulnar dimelia, more commonly known as mirror hand. And the mirror hand part, while certainly not straightforward, pretty accepted steps for treatment. And I don't want to bore anyone. So I'm going to jump to the part which is more uncertain and more challenging, which is the elbow. So and I share this not because I want to bore people with the details of how to treat mirror hand and ulnar dimelia with limited elbow motion, but I think some of the principles of what we did felt really good. But very briefly, just to set the stage, if you have two ulna bones and they come together at the distal humerus, essentially what happens is the child can't flex. And so elbow surgery is designed to try to restore at least passive, if not active, flexion to some degree, because we all know that a straight elbow is not functional. Eating's tough and many daily activities are tough. And so my personal philosophy is to do this surgery younger to give the joint time to remodel after you do what you do. And we did the surgery. It felt very good. But what I liked most was our planning and the kind of the cognitive exercise around it. We got a CT scan and 3D reconstructions on the CT scan. We got an MRI, which honestly was not as helpful as a CT, but I was curious about the muscle development, but it wasn't the best MRI, so I couldn't learn as much as I wanted. But what I did, which made me really, really happy, was I got a 3D model printed of the elbow. And again, it's a 3D model of the bone, which doesn't reflect the cartilage, but it is really, really helpful in strategizing how to approach the elbow and what we might need to do. And it's a fascinating limb development problem. And we spent a lot of time. We got the result we wanted. We got about 80 to 90 degrees of flexion. And super fun. And I think those are great exercise for myself, but also for the trainees, and Dr. Wall partnered with me on this surgery.
Super, as been pointed out before, super interesting is something we like to say here around these parts. When you do that, what do you do with the model at the end of the case? You don't just chuck it, do you?
Definitely not. There's a couple of funny things. One, I haven't worked with this particular 3D printing lab, and I said, hey, is there any way you can make a model? It was kind of last minute, and he says, no problem, I'll get it done. I'll print it over the weekend. I'll be ready for you on Monday. And
then he's like, what the hell is this? So they're two ulnas?
No, but we had a little phone Zoom and we talked about things. But what was interesting was he printed it, 1-to-1 to the CT scan, which was essentially life size, which was like this big because it was a young kid. And so I talked to him later and I said, can we just scale that next time and do it 2-to-1? He's like, of course we can. You just got to ask. I'm like, all right.
Maybe he just assumes since you're a peds ortho surgeon, you're just used to operating on small stuff.
It's true. It still was helpful, but it's sitting on my desk. I love it on my desk. It's going to stay there forever.
So is there ever any reason to get another CT scan on this child? And then could you get another model printed to show the work that you did?
What would be really interesting, and there's really almost nothing in the literature. One of my friends from Japan actually has a pretty reasonable article which describes sort of what we did, but there's so little because it's an uncommon problem and blah, blah, blah. But I do think it would be interesting because the ulna bones are rotated. So they're not sitting directly posterior. They're both rotated around a little bit. So they're kind of sitting at 45 degrees to one another. And so that may limit in the future motion. I would love to know what the elbow joint looks like at 8 years of age or at skeletal maturity. It would be fascinating for sure.
I'm wondering if there's a way to do it in a obviously radiation conservative manner. But yeah, that'd be super interesting. There, I said it again. Very interesting.
Who was giving us grief about that? I don't remember who it was, but it was funny.
That is pretty funny. So I have one more case to share, and I don't know if you have any other ones, but we talked about it before on the podcast, and I can't remember. I've probably said it in other venues, but I think we vastly underestimate the amount of trauma that gunshots do to nerves. And unfortunately, being in St. Louis, we see a fair bit of firearm violence, and we wrote about that recently in JBJS, and it's only spiked since the pandemic. And two cases, both recently. One with a bullet that went through the deep perineal nerve and just skirted right by the superficial perineal nerve, like almost impossible shot. But had a very anatomically matched palsy. Had intact eversion, kind of dysesthetic in the SPN distribution, but pretty normal, and a completely dense deep perineal palsy. And of course, there was a fibula fracture in the same location. You could see where the bullet was. I mean, it was remarkable. And again, ultrasound saved the day. Told us that there was a partial transection of that nerve from the bullet, allowed us to act sooner, and I think gives us a much better chance to make things better. And then another related case was.
Hold on. So how soon do you prefer to act? You saw the patient, you got the ultrasound. Is this something you want to do in the first 2 weeks, or what's your goal?
I think that we don't really know, and I hope that some enterprising and bright young hand surgeon or therapist will try to understand this, but we don't know how long it takes for that zone of injury to truly declare itself and in what situation. I think many of us have accepted 3 weeks roughly as the amount of time it takes. So this patient, was seen in the clinic about 3 weeks out from the injury, had an ultrasound done the next week, and was in the OR by the 5-week mark. And knowing that we're going to have to graft, and now has a very reasonable graft length and is within a very reasonable time frame to see recovery.
Yeah, that's awesome.
And again, another gunshot wound, but a gunshot wound to the proximal forearm. And kudos to one of our trauma colleagues who, when they were plating the proximal radius from a dorsal approach, was kind enough to find the PIN and tell me that it was completely transected. So helpful, because I'm not going to sit and wait and watch this one. It didn't even need to get any imaging or anything like that. Got them back to the OR within a few weeks, and completely through the PIN. Like right where it was intact, kind of halfway through the supinator and towards like the distal 2/3 of the supinator, just blown apart. And then for those of you that are familiar with the branching pattern of the PIN, after it, maybe about 2 or 3 centimeters after it emerges from the distal end of the supinator, it splits into that superficial branch, which tends to go towards the 4th, 5th, and 6th compartment, and then a deep branch, which tends to go to the thumb, so the 1st and 3rd compartment. And the anatomy was just beautiful, but seeing how it was just transected, just proximal to that bifurcation, gave us a fighting chance with the graft. I also added a distal nerve transfer because there was a kind of a freebie branch to the EDC. So I took the AIN from the pronator quadratus, flipped it backwards through the interosseous membrane as described by Bertelli, but instead of putting it into the thumb extensors, put it into the EDC because I figured I'm there, might as well give it a shot.
Wow, well done. I have seen 2 gunshot wounds right at that bifurcation at the distal end of the supinator, and that is tough when you have small branches and a segment that's destroyed. That is really tough. So I do think your patient was somewhat lucky, and I think adding the nerve transfer is a no-brainer.
Yeah, it was, and I think it was a good example of, we talked about earlier, that radial tunnel surgery. It's a good example of being facile with all the approaches, because in order to find healthy nerve, I had to go back anterior and kind of do the approach at the arcade level, find a healthy nerve. And honestly, the supinator just looked like mush, even though theoretically its innervation had already come in. just didn't look great because of all the direct trauma to it, but then found the nerve there that allowed me to work back on the dorsal side and put the graft in. And again, because we got there within a reasonable amount of time, reasonable graft length and a decent chance of recovery across the graft.
Yeah, I love it. Love it. Awesome. All right, this has been fun.
But yeah, a little grab bag episode. If anybody has any questions, they want to email us. The thing handpodcast@gmail.com, or leave it in a review. Chuck likes positive affirmation and feedback, so please provide that for him and me, but mainly Chuck.
For sure. Please do that. I'll leave you with, I am grateful for spring. That's it.
Yeah, I haven't lived in St. Louis that long, but these up and down spring things where it's like 70 degrees one weekend and like 30 the next weekend with snow, I don't like it so much. I do like the spring weather though, so my my thing I'm grateful for is also spring.
Totally agree. All right, man. It's been fun. Thank you very much.
All right, see you next week.